to learn, and to love this life we have. We pray that we may use what we learn today to better care for ourselves and our loved ones. We pray for everyone present here today that we may all live life to the fullest, with purpose and good intention, and always with kindness for others. Keep us safe, keep us healthy, and keep us hopeful as we live each day for your greater glory. Amen.
Mga kababayan, ang pambansang awit ng Pilipinas.
Puso ko'y tinig ng kasayahan, dahil ako'y nasama sa tanan. Ang lahat may gintong nasa, makisig at masigla. Kapisanan ay tunay ang damdamin, suliranin itong baya'y pawiin. Inalangin natin ang tapat sa may kapal, ay lunas sa lahat. Awit ng DNA, tayo ay mag-iwan. Magtulungan, pagunlad ng bayan. Ang kailangan, ibigay sa kanan, kalusugan at kasaganahan. Ang puso ko'y tigib ng kasayahan, dahil ako'y nasama sa tanan. Ang lahat may gintong nasa, makisig at masigla. Kapisanan ay tunay ang damdamin, suliranin itong baya'y pamilin. Inalangin natin ang tapat sa may kapal, may lunas sa lahat. Inalangin natin ang tapat sa may kapal, may lunas sa lahat.
call Dr. David Calapatia to welcome everyone to tonight's webinar.
Magandang gabi po sa ating lahat. According to the Department of Health, colon cancer ranks 66 overall, 5th among the males and 7th among females. Colon cancer increases markedly after age 50. Welcome to the Olongapo City Medical Society's 12 Cancer Awareness Lecture. The series of cancer lectures are given through the leadership of the Olongapo City Medical Society President, Dr. Raymond Joseph Manzo. So sit back and join us to learn more about colon cancer. Thank you all for your continued presence to the Olongapo City Medical Society's activities. Have a good evening, everyone.
Thank you, Dr. Calapatia. This advocacy has been inspired because of the staggering statistics that we are faced nowadays. And the thing about cancer is that this is a preventable disease. That's why the OCMS in its advocacy this year has emphasized the need to be aware about cancer. This evening, we will discuss on colon cancer awareness. It's Colon Cancer Month this March, and this is our last on our series of cancer advocacy. Pero abangan po ninyo, meron pa kaming mga infomercials na darating for the month of April and May regarding the cancer awareness advocacies that we celebrate for the following months. Ngayong gabi po, ating pag-uusapan ang screening for colorectal cancer. Lagi niyo pong naririnig yung screening. Ano ba ang kahalagahan nito sa pagpe-prevent ng cancer sa ating katawan? So ito lang po, statistics na nabanggit na rin po ni Dr. Calapatia at babanggitin din po ulit ng ating speaker mamaya ang mga nakakatakot na cancer sa Pilipinas. Napag-usapan na po sa cancer advocacy series natin, yung breast, yung lung at yung liver. So nandun po tayo sa top 3 cancer na yung gabi. So paalala lang po, alam ko pong sawang-sawa na ang lahat sa webinars na ginagawa natin itong pandemic. So please keep your gadgets on mute mode. Turn off po ang mga cameras natin during the lecture proper, but you may turn them on during the open forum. Kung makaproblema po sa connectivity, you just log out and re-register either by clicking the link, scanning the QR code in your posters that was sent to you, or manually entering the meeting ID and the password. Meron po tayong open forum or question and answer portion after the lecture, so just type your questions in the chat box. Ang ating pong lecturer or resource speaker ay malapit po sa ating mga puso, lalo na po sa puso ko. So siya po ang kasalukuyang presidente ng Olongapo City Medical Society. Nagtapos po siya ng pagmemedisina sa UST at doon din po nag-training bilang isang sirohano. Kakatapos lang din po niyang mag-masters in hospital administration. Siya po ay fellow ng PCS, ng PSGS at ng PALES. Nakasulat naman po sa inyong screen ang kahulugan ng mga acronyms na aking nabanggit. Dati pong naging presidente din ng PCS Central Luzon, naging governor ng PCS Central Luzon Chapter. Dati pong training officer ng James L. Gordon Memorial Hospital Department of Surgery at kasalukuyan pong board examiner sa Philippine Board of Surgery. Ang ating pong speaker ngayong gabi ay si Dr. Raymond Joseph Manzo.
Thank you, Arl. Malapit sa puso. Malapit talaga sa puso ang gastroenterologist sa akin. So, asan na? Okay. So again, thank you everybody for joining us in this last of our series of lectures for our cancer advocacy for the year 2021-2022. Okay, sorry. So preventive medicine is one of our subjects in medical school. This minor subject, which was also quite boring to learn, appears to be one of the more crucial aspects of bringing quality healthcare, as I have come to understand today. I did not realize it at the time, but now I see how much more important it can be to be able to prevent disease rather than to help cure it. Our cancer advocacy lecture today is a part of our series, as mentioned by our moderator. We have bombarded you all with these information tidbits in the hopes of making a difference by bringing awareness of this deadly disease. This month, we celebrate colon cancer awareness together with the rest of the world. The COVID-19 pandemic is now slowly making its way out of our lives, hopefully with no looking back once and for all. Unfortunately, it has added to its aftermath the impact on our preventive healthcare system. Cancer screening has taken a backseat these past 2 years as we prioritize more urgent medical and surgical needs in the midst of the COVID crisis. Cancer, being second to COVID as the most common cause of deaths since the pandemic has begun, should warrant more attention than what we are giving it. As of the GloboCan 2020, the latest data I could come up with so far, colon cancer remains to be the third most common cancer and the second leading cause of cancer deaths worldwide. Locally, it is the same, being the third most common cancer affecting us Filipinos. These data are quite saddening because colorectal cancer is a preventable disease. Now, with all that scary information at hand, I hope to be able to bring awareness to all of you that colorectal cancer is one of those diseases that we can prevent. So for my talk, I will be giving you a quick look on the risk factors and symptoms of colorectal cancer, but the bulk of our discussion is on colorectal cancer screening. Finally, I have a few slides on treatment and prognosis as well. Risk factors can be modifiable or non-modifiable. It is as simple to explain as it is described. May mga risk factors po na pwedeng ma-adjust, matanggal, or makorek, and these are the modifiable ones. And yung pong mga bagay na binigay sa atin ng genetics and heredity, these are the factors that we cannot change, correct, or adjust. These are the non-modifiable risk factors. Let us run through these risk factors one by one. Now, for colorectal cancer, family history is one of the important non-modifiable risk factors. Around 30 to 40% of colorectal cancer cases are hereditary. Kung meron pong first-degree relative, magulang or kapatid na nagkaroon, that person has a 50% chance na mamana ang sakit. This risk further increases if 2 or more relatives are diagnosed with colorectal cancer, at kung ang kamag-anak po na nagkaroon nito ay sa batang edad na diagnose, meaning below 45 years of age. There are other inherited conditions related to colorectal cancer, but the good news is these are rare syndromes. Ngunit kung may mga kamag-anak po kayo or patients who may be diagnosed with these, they have to be advised to get regularly screened because these illnesses are associated with an increased risk of colorectal cancer. Screening procedures for colorectal cancer, as you will see in the guidelines I will present later, begin at ages 45 to 50 years old. And this is because current data show that majority of colorectal cancer affect those age 55 and above. My slide will show some of the famous 50-somethings that you might all know. I was surprised na they are that old na pala, and I can only hope that when I turn 50, I won't look my age too. For example, Paul Rudd, si Ant-Man ng Avengers, he is 53. Snoop Dogg, he is 51. Matt Damon or Jason Bourne, pero sa mga contemporaries ko po, he can be seen in Good Will Hunting, an iconic movie during my time. He is already 52. Of course, who doesn't know Jenny from the Block, J-Lo, who is already 53 years old. And you had me at hello, Renee Zellweger, also 53 years of age. I've come across data that shows a cumulative increase in colorectal cancer incidence from 2003 to 2013 in those less than 50 years of age. Ang importante po na message nito sa atin is that we are not exempted from getting colorectal cancer even if we are not yet 50. So we have to be vigilant in propagating screening awareness, identifying risk factors, and addressing symptoms that may suggest this disease and get diagnosed as early as possible. There are studies that show an increased male preponderance for colorectal cancer, but it affects men and women equally. Some evidence show that females are more prone to get right-sided colon cancer and men more of the left-sided colon cancer, and it has something to do with the genetic makeup of the tumors affecting sexes. The take-home message though is though men have a slightly higher risk, both sexes may get colorectal cancer So regular screening applies to both men and women. I am sure you all know Black Panther, Chadwick Boseman, napakagaling na African-American actor who died at a young age from colorectal cancer. It was said that he was already diagnosed with stage 3 colon cancer in 2016, and he was 40 then. His disease progressed to stage 4 in 2020. Habang ginagawa po niya yung mga pelikula niya during this time, already having been operated on several times and undergoing chemotherapy. He sadly died at a young age of 43. Another race at risk for colorectal cancer are the Ashkenazi Jews of Eastern Europe. Another non-modifiable risk factor is the diagnosis of IBD, or inflammatory bowel disease. This illness has been initially recognized only in our foreign counterparts, but nowadays we see more Asians, more Filipinos affected by it. As its name implies, this disease is defined by a state of chronic inflammation, hence putting an affected person at risk for developing malignancy. The implication is that people with IBD need to be screened earlier and more frequently. Now, people who are polyp formers may have an increased risk for developing colorectal cancer because malignant tumors of the colon almost always come from these polyps. They don't have symptoms while they are small, but no matter their sizes, once they have a malignant potential, they stay in our bodies, they can become cancer. So the wisdom behind getting screened is to identify these asymptomatic polyps and have them removed before it is too late. Women who had been diagnosed with ovarian and uterine cancer may have a higher chance of getting colorectal cancer, so they have to be screened early and vigilantly. People who survived colorectal cancer in the past may still be at risk of having colorectal cancer again, so the surveillance for these patients should continue on despite being cured from their first one. Diabetes mellitus and colorectal cancer share common risk factors and are both becoming more prevalent even in young adults. Diabetes diagnosis has been linked with an increased risk of colorectal cancer. Many suggested theories support this relationship. One observed relation is that of hyperglycemia or mataas yung asukal sa katawan and an increased risk of cancer. These studies done from 2017 up to present show evidence of this association, so we must be able to advise our diabetic patients to also get screened as early as possible. Now we move on to modifiable risk factors. Smoking, not just for lung, oral, nasopharyngeal, and pancreatic cancer, but it is also a significant risk factor for colon cancer. A person's first smoke, how long he or she had smoked, and how many sticks consumed per day are factors related to risk of colorectal cancer. I need not elaborate more because we all know naman po that smoking kills. Naging problema ito ng karamihan sa atin nitong pandemic. Our physical inactivity, our sedentary lifestyles. Naging best friend natin ang ating mga gadgets, TV, screens, and out of fright from getting sick and following restrictions from going outside, we have inadvertently hurt ourselves in the process. Being sedentary is associated with heart disease, diabetes, and also colorectal cancer. Mas active po ang lifestyle, the lesser risk of getting colon cancer. Ayan po, isa pang naging epidemic ngayong pandemic, weight gain and obesity. So kasabay ng kawalan ng exercise is kumain din tayo ng kumain. And this has increased once again our risk to develop a lot of illnesses, and colorectal cancer is one of them. While doing this lecture ay nakakakaba po talaga dahil ang daming risk factors ang na-identify ko mismo sa akin. So let us be motivated together to start the change and save ourselves from getting sick. Yan, masyado na po bang masakit sa tenga yung mga sinasabi ko? So yes, our diet has a role in our general health, of course. And sadly, the delicious food we take in excess can get us sick. Reiterate ko po, in excess. Increased intake and consumption. Hindi naman po totally bawal that we have to avoid everything. We must just learn to eat in moderation and keeping in mind that foods that may put us at risk of getting sick. If the previous slide tells us what to avoid, now we will talk about what we can take to protect us from colorectal cancer. Increasing our fiber intake lessens our risk of forming polyps and also our risk from getting colorectal cancer. Folic acid supplementation has been shown in studies to also be protective for colorectal cancer. Calcium and vitamin D intake as well. Kung medyo nakaka-constipate po sa inyo ang calcium supplements, vitamin D on its own can help. It also, in addition, increases our gut and overall immunity. My wife started the whole family on vitamin D supplements ever since the pandemic started, and I plan on continuing taking it for colorectal cancer prevention as well. Knowing now what we can do to protect ourselves from getting colorectal cancer, ngayon naman pag-usapan natin, what are the symptoms to watch out for? People with colorectal cancer may experience the following symptoms or signs. Abdominal discomfort or pain can be described as frequent gassy pains, bloating, fullness, and cramps. Typically, the patient presents with lower GI bleeding, described as bright red or very dark blood in the stool. There may be weight loss with no known explanation. Hindi sinasadya, hindi nagda-diet, pero nababawasan ng timbang. The appetite has changed. Some even would complain that the food has no taste. For those with right-sided lesions, there may be no outright bleeding, no pain, or changes in stool character, hindi pumapayat yung dumi, but they have unexplained iron deficiency anemia. Constipation or changes in bowel habits are typical for those with left-sided lesions. Obstipation or lacking the ability to pass gas or stool, hirap umutot, may be seen with obstructing left-sided or rectal lesions. Abdominal enlargement occurs if the tumor has caused complete obstruction or if ascites or fluid in the abdomen is present. Just to stress some key points, don't underestimate blood in the stool. It might not be what you think it is. Always rule out cancer for any bleeding per rectum, especially for those with average or high-risk individuals. So hindi lahat amoebiasis or hemorrhoids. Significant anemia detected in routine complete blood count need to be investigated further to rule out colorectal cancer. Hindi po simpleng reseta ng iron supplements ang sagot sa anemia. Importante pong imbestigahan ano ang sanhi ng anemia. And for the non-MDs listening, hindi po nakaka-anemia ang puyat. Pag may abnormal sa CBC, consult your doctor. So now let us move on to the highlight of this evening's talk. How do we screen for colorectal cancer? There are stool-based tests we could use, and the most popular one used for fecal occult blood testing is the guaiac test. The idea behind this is that blood vessels at the surface of large polyps or tumors are fragile and may easily be injured with the passage of stools. These damaged vessels will only release minute amount of bleeding, which will not be seen by the naked eye. The heme in the blood will then react with the chemical guaiac and will cause a change in color. Hence, this is a way of identifying microscopic amounts of bleeding. However, we see a lot of false positives and false negatives with this test. So at the moment, it is no longer recommended as the stool-based test for colorectal cancer screening. The fecal immunochemical test, on the other hand, uses antibodies that specifically react with the blood protein in the stool. It is a newer, more specific type of fecal occult blood testing, which is highly sensitive to low concentrations of human globin, or the protein component of the hemoglobin molecule, and does not get affected with medication or food intake as compared to the guaiac test, which you have to fast for 3 days na walang meat. The stool DNA testing is another non-invasive lab test that identifies DNA changes in the cells of a stool sample. The stool DNA test looks for abnormal DNA associated with malignant tumors and polyps. Hence, also another sensitive and specific test for fecal occult bleeding, but at the moment is not yet readily available in our setting. These stool-based tests are used for screening. If a patient presents already with blood in the stool, there is absolutely no need for requesting these to patients. Once these stool-based tests show positive results, additional testing is then required to identify the cause of that positivity. So these patients are then advised to undergo a lower GI tract endoscopy or what is known as colonoscopy. Trained gastroenterologists do this using a flexible endoscope to directly visualize the entirety of the large intestine. The most important element of this procedure is once a polyp has been seen, the endoscopist can remove that polyp and completely eliminate the risk of that polyp turning into a cancerous lesion when left behind. This screening procedure is the most recommended modality from almost all society guidelines, and it has very strong level of evidence as well. A flexible sigmoidoscopy may be another option for screening. What is different is that this will only visualize up to the level of the sigmoid colon. As you can see in this diagram here, that is approximately at about 25% of the colon's entirety. The basis behind this test is that there is existing evidence that most colon cancers grow on the left side of the colon. Because this modality would not be able to visualize the entire large intestine and polyps or tumors can grow anywhere, of course, the level of evidence in using this as a screening test is much lower than that of a full colonoscopy. There is another way to visualize the colon through endoscopy, and this is by way of the colon capsule. The patient is made to swallow a capsule with a camera built inside it, and by way of a transmitted video image, the gastroenterologist will watch this capsule camera recording as it goes down from the esophagus down to the anus. Not only is this very costly, I believe this procedure costs around 50 to 80,000 in our country. In addition, should polyps or a malignant tumor be seen, a therapeutic colonoscopy would have to be done to remove or biopsy these lesions. So added procedure, added bowel prep, and of course, added cost for the patient. Now, what about a virtual or a CT colonography? This is more specialized than an ordinary contrast CT scan because this is intended to specifically find lesions in the colon. Preparation is the same, bowel should be cleared out, then the patient is made to take contrast medium. There will then be a tube inserted into the rectum on the day of the test to inflate the colon for the procedure. The CT scan will then take pictures afterwards. Just like the capsule endoscopy, this modality is purely diagnostic and would need a separate therapeutic endoscopic procedure to remove or biopsy the identified lesion. Another caveat of this test is that sometimes fecal material may be mistaken as polyps or vice versa, and small polyps less than 5 millimeters might be missed. The barium enema is simply an X-ray of the large intestines taken after contrast is administered through the rectum. This is actually intended for identifying larger lesions as small polyps less than 1 cm may not be identified using this test. Moving on to the recent screening guidelines, the Philippine Society of Gastroenterology and the Philippine Society of Digestive Endoscopy presented its own consensus guidelines on colorectal cancer updated last 2016. In these guidelines, they recommend colorectal cancer screening at age 50 for average risk and earlier for high-risk individuals. Annual stool occult testing using the FIT is their recommendation, flexible sigmoidoscopy every 5 years, or a colonoscopy every 10 years. The American College of Gastroenterology has similar recommendations, screening at age of 50 for average risk, but they do suggest earlier screening at age 45 to 49 to reduce incidence and mortality from colorectal cancer, which is a grade B evidence. They also strongly recommend colonoscopy and FIT as the modalities of choice for screening. The National Cancer Comprehensive Network, or known to us doctors as NCCN, recommends screening for average risk individuals to begin at age 45. So again, these are the screening recommendations for average risk individuals or people with only age as the risk factor identified. Now, for the high-risk individual, for those with increased risk based on family history, it is recommended that they get screened as early as age 40 or 10 years before earliest diagnosis if there is a first-degree relative with CRC, or those with polyp findings on endoscopy with biopsy results which are high risk for malignancy. For those with second or third degree relatives with CRC, they must be screened at age 45. Patients with suspicious symptoms or what we call alarm symptoms must be advised to undergo a colonoscopy as soon as these symptoms arise, regardless of age. Therefore, these symptomatic patients are not considered as screening anymore. For patients who are diagnosed to have colorectal cancer via colonoscopy and or other modalities, this just shows how we approach treatment of patients. Colorectal cancer is treatable just as it is preventable. Gone are the days that cancer diagnosis spells a death sentence. Advancements in medicine and surgery make our cancer patients survive their illness. It is important to stress that not only early diagnosis plays an important role in good patient outcomes, but also effective treatment. That is why we must always be guided on how we can provide best choice of appropriate management for each cancer patient. So as a surgeon, oncologic resection is the mainstay of treatment. Ang ibig pong sabihin nito ay hindi po basta mag-opera lang pagdating po sa paggagamot ng cancer. Kailangan po na nararapat ang choice ng operasyon at kailangan po masiguro na walang matitirang cancer as much as possible and with adequate margins. These are pictures of the different types of cancer surgery techniques that we do as surgeons based on the location of the tumor. Mahalaga po na malaman yon upang mapagplanuhan pong mabuti ang operasyon na kailangan ng pasyente. Kailangan po ang kompletong operasyon at hindi basta tanggalin lamang ang bukol. The resection should include lahat ng taba or yung tinatawag na mesentery dahil nandito po lahat ng kulane, which is very important to clear the surgical field for staging and for prognostication. The arterial supply to that portion of that colon to be resected is cut from the origin itself, so bawal ang shortcut. You may take as much as possible. What about surgical approach for oncologic resection for colorectal cancer? I'm sure most of you are familiar with laparoscopic cholecystectomy. A comparison between open laparotomy, wherein a large incision will be made, against laparoscopy, which uses keyhole incisions and advanced instruments, shows that laparoscopic colectomy results in an overall better patient experience after surgery and with similar oncologic outcomes. One disadvantage is the additional cost, which may be balanced out by reduced hospital stay and need for pain medications. Sa bawat pasyente po diagnosed with colorectal cancer, ang next step po is yung tinatawag na staging and metastatic workup. Dahil magbabago po ang plano, depende sa stage ng bukol or cancer. Identifying if this is stage 4 cancer can be done preoperatively after an ultrasound, chest x-ray, or better yet, CT scan and or an MRI that we request to assess any metastatic lesion. If metastatic workup is negative, we automatically aim for cure. To determine the adequate stage of the lesion, makikita po natin yan pagkatapos ng operasyon at ma-examine na ng pathologist yung bukol na tatanggal. For metastatic disease, our plan will be different. Surgery might not be the initial plan of action, and chemotherapy may be the preferred course of action. There are times though that even if the patient has metastatic cancer, surgery may be warranted to palliate bleeding or obstruction. So hindi porket stage 4, hindi na kailangan operahan. Bottom line is we have to, as much as possible, come up with an adequate diagnosis, then do appropriate treatment to ensure patient survival and improve the quality of life. Minsan po ang kalat ay hindi pa ganong kalala at kung kakayanin po ng pasyente, maaari na po nating operahan at tanggalin din ang kalat or metastatic lesions. What this means is though the diagnosis at the onset is metastatic, the patient may still have a chance for cure after oncologic resection of the primary tumor and resection of the metastatic lesion or yung tinatawag na metastasectomy, with an increase in 5-year survival to at least 20%, and as high as 71% for solitary liver metastasis only. For stage 3 disease and some stage 2 disease with high-risk features, the patient will need what we call adjuvant chemotherapy or chemotherapy pagkatapos ng operasyon. Ang purpose po nito is to kill any microscopic cancer cells left in the body, nung nasa dugo na yung cancer cells, and at the same time to decrease the chances of disease recurrence. Again, our aim is to go for cure, so beyond surgery, we need to do more. Kapag rectal cancer naman po or kung mas mababa ang lokasyon ng bukol, kung malapit po sa butas ng puwet, nag-iiba po ang steps natin sa pagpapagaling ng pasyente. Kumpara sa colon cancer, operasyon muna tapos chemo. Sa rectal cancer, baliktad. So after the lesion has been identified, and this is usually after an endoscopic procedure, the next appropriate step is to assess the extent and possible metastasis of the tumor, so staging. Sa rectal cancer po, most of the time, nauuna ang chemo at kasabay po nito ang radiotherapy bago po mag-opera. Bakit? Because sa rectum, masikip ang lugar because of the pelvis as compared to the colon na wala halos nakadikit. So invasion of the tumor and lymph node spread will make complete resection difficult in the rectal surgery. Neoadjuvant chemoradiotherapy is essential to increase the chance of success for complete resection. So less bleeding during the surgery, it may lower down the patient's stage, it increases local control, thus decreasing disease recurrence and may affect overall survival. One of the recent improvements in cancer care is a multidisciplinary approach wherein all stakeholders, yung surgeon, oncologist, radiation oncologist if needed, pathologist, nurse, other internists, including po yung patient and relatives, sit down and have a meeting or conference to discuss all the options and come to a consensus to the best treatment approach para sa specific patient. In this way, the whole team will be on the same page for the patient. Alalahanin po natin na ang cancer treatment doesn't end with surgery and the need for adjuvant treatment and surveillance is a must. So is colorectal cancer curable? Yes, lalo na po kung wala pa itong kalat sa ibang organs. If the diagnosis was made at an early stage and if the treatment is appropriate for that patient. Based on these very optimistic tables, localized colorectal cancer has a 90 to 93% 5-year survival rate. But as you can see, for stage 4 or metastatic disease, 5-year survival rate is greatly impacted. Pero if you remember, depende rin kung gaano kalala yung metastasis, baka pwede pa nating i-offer yung metastasectomy. So the take-home message here is get screened, get early diagnosis, get treated as soon as you are diagnosed, get appropriate treatment, and all of these will assure better survival. Is colorectal cancer preventable? Yes, very much so. And it is up to us to modify our risk factors as much as we can. Motivate ourselves and our loved ones to get regular exercise, stay active, eat healthy, maintain as much as possible a normal weight, decrease our waist circumference, avoid or stop totally vices like alcohol and smoking, and to supplement with folic acid, calcium, and vitamin D. And of course, polypectomy during screening colonoscopy will eliminate the risk of developing colorectal cancer in the future. That's why we can't stress enough the importance of screening for all patients. So with that, I hope I was able to give you everyone tonight enough information and not to frighten you, but to make you aware that colorectal cancer is not as intimidating as we think, and that we can fight it by being vigilant about screening. Colorectal cancer is preventable, treatable, and beatable. So good evening and salamat po sa inyong oras sa pakikinig.
Thank you so much, Dr. Manzo. Napaka-high yield po ng inyong lecture. Ibig sabihin, ang dami naman nating natutunan this evening. Pero bias ha. So, meron pong mga ilang nagtanong, kaso nag-private message po sa akin, parang nahihiya yata kasi medyo censored yung tanong. Umpisahan ko po nung isang tanong na sinend sa akin. Meron pong nakapagsabi na kapag daw po nagpipigil ng pagdumi, pasintabi po sa mga nagdi-dinner, isa rin daw po itong risk na magkaroon ng colon cancer. So dapat pag na-feel mo na yung urge, punta ka na ng banyo. Ano po ang masasabi niyo tungkol dito, Dr. Manzo?
Well, wala naman akong nabasa sa mga guidelines na yung pagpipigil ng dumi increases the risk of colon cancer. It may increase the risk of hemorrhoids, diverticular disease, but not really colon cancer itself. Now, pwedeng i-conclude based on yung sinabi ko po kanina na fiber intake decreases the risk of colon cancer. So pag constipated po, ibig sabihin kulang ang fiber, baka pwedeng magkaroon ng mga polyps, magkaroon ng polyp formation which can lead to colon cancer. But yung directly correlating yung constipation with colon cancer, parang wala po akong nabasang ganon. But anyways, it is not healthy na magpigil. If you have to go, you have to go. Ngayon, pag nandun ka na sa, grabe no, yung usapan natin sa bahay, ganito eh. So pag nandun ka na sa banyo, you have to also evacuate and don't stay too long. Okay? Because that will lead naman to hemorrhoidal disease.
Sige. Isa pang question. Very prominent na yon, usong-uso yung mga ina-advertise na colon cleansing. And some of these colon cleansing herbal preparations claim to prevent colon cancer. Ano ang masasabi mo dito?
Marami po kasi talagang lumalabas na mga herbal colon cleansing, etc. na ganyan eh. But the colon cleansing, all they do is just flush the large intestines of contents para ka lang naglabatiba. But it doesn't mean the risk of colon cancer is eliminated. That's why it is really important na kahit na kunyari nag-colon cleanse ka, we don't even know the components of the colon cleanse. Pwedeng herbal yon, it might have side effects, but definitely the benefit will not be outweighed by the risks of the side effects. So kahit na hindi ka mag-colon cleanse, the most proven, yung mga established na data na po to really prevent progression of colon cancer or development of colon cancer is screening talaga. 100% screening. The other risk factors can contribute. Pero po, lahat po ng colon cancer talaga nagsisimula po sa polyp. At ang polyp, hindi po yan mararamdaman. Wala po kayong mararamdaman pag may polyp po kayo. Makikita na lang po yan sa colonoscopy.
Okay, so ang mga herbal preparation claiming to colon cleanse ay hindi nakaka-prevent ng ating chances to have colon cancer. So another private question, dinidirect message kasi nila ako eh. Will anal warts increase the risk for anal or rectal cancer? Yung
Okay.
mga, I believe this is an STD, no?
Yes. It will not increase the risk of colon cancer, but it will increase the risk of anal or rectal cancer because yung culprit or yung causative agent ng anal warts is a virus, yung human papilloma virus. So meron po yan direct correlation with development of anal cancer and rectal cancer. Now, kaya nagkakaroon yan because of, again, unprotected intercourse, especially with males. So ang nangyayari po, nagkakaroon ng repeated trauma dun sa mucosa ng anus at rectum. Yung repeated trauma na yon or repeated na sugat ng sugat, pwede po yan mag-develop into cancer. So meron po.
Para lang po maliwanagan ang non-medical audience, people in our audience, ano ba ang difference, Dr. Manzo, ng anus, rectum, and colon?
Okay.
Kasi sabi mo, risk for anal and rectal but not for colon cancer. Di ba pare-pareho lang yon?
Ang colon po kasi mahaba yan, almost 100 centimeters in total. Yung pong anus, yung po yung balat na component, yung nahuhugasan natin sa puwet. Pagpasok po sa loob niyan, magbabago para magmumukhang labi yung itsura. So that part is already the anal canal. Tapos 4 centimeters above, is the rectum already, hanggang 12 centimeters. So kumbaga parang leveling lang siya. Anus, bungad, rectum medyo kumbaga sa bahay foyer. Tapos yung mismong bahay mo is yung colon mismo. So yun ang difference by anatomy. So yung sinabi ko rin na pag rectal cancer, masikip kasi nasa pigi, nasa in between ng buto. So pag doon nag-develop, mabilis siyang dumikit sa side walls, mas mahirap tanggalin ng buo. Kaya binabaliktad po yung sequence ng treatment. Meron pong mga pasyente, we experienced that before na makulit. Kahit na sabihin mo magpa-chemo na, magpa-radiotherapy muna bago mag-opera, they would insist on having surgery first. Kahit na sabihin mong mas maganda yung advantage. Bakit? Kasi kahit naman ano yung unahin mo, they will go hand in hand. Hindi pwedeng mag-opera ka lang na walang chemo. Hindi ka pwedeng mag-chemo na walang operasyon. So, package deal siya. So kahit na baliktarin mo yung sequence, mas maganda yung sequence sa rectal cancer pag inuna yung chemo and radiation. So that's the best course.
Okay, very well explained. Next question po from Dr. Calapatilla. Kung limited ang budget, what test should one do to diagnose colon cancer? I think this is also one of the private questions asked to me. Dito daw sa Olonga po, meron daw bang option na mas mabilis at mas murang test for screening? When do we do CEA is for the follow-up question of
Sige
Dr.
po.
Calapatilla.
Okay. Yung pinakamurang test is the FIT test, comparing it with a colonoscopy, if I'm not mistaken. However, yung FIT test po kasi, every year mong gagawin yon. So, tapos, pag nag-FIT test ka, nag-positive ka, kakailanganin pa rin ng colonoscopy. So, it won't be really cost-effective. Ang pinaka-cost-effective way of really screening is still a colonoscopy because it evaluates by specificity and sensitivity. It's almost 98 to 99% specificity and sensitivity for colon cancer, even polyps. Kaya po, kung susumahin mo, nagpa-FIT test ka every year, tapos nag-positive ka, mauuwi ka rin sa colonoscopy. So better to do the colonoscopy first. Now, other guidelines will also say na pag kunyaring hindi naman average risk, hindi low risk lang siya, pwede naman magkaroon ng flexible sigmoidoscopy plus the FIT test. Kasi nga hindi masiscreen yung right side with a sigmoidoscopy. Pero as it's really in the guidelines already that the colonoscopy is the most cost-effective way of screening for colon cancer. And it is parang effective siya or kumbaga walang expiry. Hanggang 10 years is your repeat colonoscopy. Unless you find polyps, so medyo nababawasan yung interval. Pag may polyps na medyo high risk, pwedeng every 3 years. But if asymptomatic and clean yung colonoscopy, as later as 10 years yung next. Now, sa CEA po, ang CEA, for the benefit of everybody, it's a tumor marker. So, examination siya sa dugo, carcinoembryonic antigen. Hindi po siya ginagamit for diagnosis. Kasi may mga colon cancer na hindi nagpo-produce ng CEA. So, pwedeng normal yung CEA, pero may colon cancer kang hindi nakikita. So, ang importance po ng CEA is for treatment. Kung kunyari po, na-diagnose with colon cancer, nagpa-CEA, tapos elevated siya, mataas. Tapos na-operahan, tinanggal yung bukol, normally bababa po yon. So during the surveillance, which is every 6 months to 12 months, nagpapa-request ng CEA. So kung bababa na yung CEA, tapos tumaas ulit, that will indicate na baka bumabalik yung cancer. So hindi po siya ginagamit for diagnosis. It is for monitoring or surveillance.
Okay. So the next question is, pag daw ba stage 4 or metastatic colon cancer, may other therapeutic option pa ba or palliative na lang? Or from Dr. Villarreal?
Pag stage 4, ibig sabihin may kalat na. First, aalamin natin gaano ba katindi yung kalat. Kasi kung isa lang kalat sa atay, isang lesion, kayang tanggalin, may role po yung metastasectomy or tatanggalin yung tumor sa colon plus yung kalat sa atay. So may advantage talaga yon. Now, kung medyo disseminated or pangit po talaga yung kalat, palliative na. When you say palliative, gusto mo lang maibsan yung mga simptomas, gusto mo medyo tumagal pa yung buhay ng pasyente. So what are the options? Pwedeng magbigay ng palliative chemo, lalo na kung hindi naman nagdudugo or nagbabara yung bukol. Ngayon, kung kunyaring nagdudugo, bumabagsak ang hemoglobin, may role po ang surgery para tanggalin lang po yung area ng bukol na yon. Or kung nagbabara, tatanggalin din yung area ng pagbabara and we end up with a colostomy. So hindi po porket stage 4 hindi inooperahan. Yung palliative surgery is mainly to address yung pagbabara, hindi na nakakautot, lumalaki ang tiyan, hindi na dumudumi, or kapag bumabagsak ang pulang dugo or nagdudugo ng sobra sa puwet.
Direct message again po. Doktora, paano po kung stage 4 na yung colon cancer? So this is, I think, in relation to the question before. Stage 4 ang patient, tapos ayaw magpa-chemo and rad dahil natatakot. Dahil mababa na yung timbang, baka daw hindi nakayanin. Ano po ang other option for treatment?
Okay. Stage 4 na payat, na chemo and radiation. Well, based on the guidelines dun sa NCCN for stage 4 na disseminated, there is a role for watchful waiting or observation. Kasi malaki din ang magiging side effect ng chemotherapy for a malnourished patient. So it's better not to touch, wala mo nang gawin. Ang iba binibigyan ng nutritional support, pwedeng nagbibigay, hindi ako magsasabi ng brand nagbibigay ng mga gatas, yan, nutritional support. Or kung hindi nakakakain, linalagyan ng tube, gastrostomy or jejunostomy, just to make sure na may nakakain yung pasyente. Kasi ang problema sa cancer, lalo na kung disseminated, I always tell my patients, yung bukol, kumakain, tumataba, lumalaki. Pero yung pasyente mismo, yung normal cells ng patient, naaagawan. So yung pasyente pumapayat.
Would you know daw po ba kung saan available ang fit test dito sa Olonga po?
Hirap na tanong yan. I'm not aware. Baka pasa ko sa'yo, Madam Moderator. May idea ka ba?
As far as I know kasi wala pa. Unless meron na. Pao, meron ba? Dr. Villarreal, pinasa. But as far as I know, it's only the guayak test that's available in our locality. Pero yung fit test po is readily available in other areas in the Philippines, just not here sa atin. I think Bataan and Pampanga, they have already.
Yun yung isang disadvantage because we rarely request for the fit test. Kasi nga, mas cost-effective yung colonoscopy. Hindi ako nagpro-promote ng mga friends kong gastroenterologist, but the evidence is overwhelming that colonoscopy is really the gold standard for screening. Ngayon, meron po akong nabasa na kasi yung compliance ng pasyente, yun nga, may cost, mahal, very invasive, patutulugin under anesthesia. There are reports that the increased compliance for screening, yung mga pasyente, mas nako-convince silang magpa-screen kung nagpapa-test na lang sila ng stool, yung fit test nga. Ngayon, kung nag-positive sila, tumataas yung compliance kasi pag nalaman nilang positive doon sa fit test, napipilitan sila magpa-colonoscopy rather than outright colonoscopy. So may data tungkol doon.
Okay. Ayan, sinagot na po nung isa pang GI natin sa audience. Wala pa. Wala pang fit test dito sa atin sa Olonga po. Another question po is pag nag-positive po ba sa occult blood after 2 cycles ng chemo, ibig sabihin ay bumalik na ba ang colon cancer?
It's hard to say kasi first of all, anong klaseng occult blood test yung ginawa? Kung kunyaring yung guayak test, yung simple, yung old school na guayak test, mataas ang false positivity rate. So eventually, you'll still have to do colonoscopy. 2 cycles of chemo after surgery, it would be really too early to say na recurrent siya. Kasi most recurrence will occur within 2 years. Ngayon, kung negative naman po yung margin doon sa surgery, madalang na magre-recur as early as the second cycle. Ibig sabihin, parang 2 to 3 months after the surgery pa lang na yon. So the best advice is still to have the colonoscopy as early as 6 months to 1 year. Especially those, kunyari, nag-emergency, na operahan, na walang colonoscopy. The earliest to do the colonoscopy is 6 months. Para siguradong walang mamiss na polyps na nandun sa bituka.
Okay. Next question, pwede daw po bang magpa-colonoscopy ang buntis?
Pwede. Pwede naman, di ba? The only contraindication ata is anesthesia. Tsaka yung ano to? Siyempre clearance ng OB. Yeah, pero I think pwede naman, there's no contraindication kasi hindi naman siya contiguous with the gynecologic organs. But the anesthesia itself is contraindication. Yeah.
You would have to have a really compelling reason why you will do it
Yes.
in a woman. Okay.
As much as possible, stay away from invasive procedures in pregnant.
Yes. May kinalaman daw ba, Doc, ang blood type sa risk factor for colon cancer? Sabi po kasi pag type A daw, mas prone magka-colon cancer.
Hindi siya related sa colon cancer yung blood type. Ang related sa blood type is gastric or yung stomach cancers. Yung sinasabing type A personality, blood type A, tapos yung mga chronic atrophic gastritis. Yun yung sa gastric cancer. But with colon cancer, walang kinalaman ang blood type. Pantay-pantay po.
Okay. How do you declare? When do you declare na cancer-free na ang patient? So this is about patients with colon cancer diagnosis na. How do you do surveillance?
Critical period is the first 2 years. So every 6 months to 1 year, for the first 2 years, battery of tests yan. Colonoscopy, annually, CEA every 6 to 12 months for the first 2 years, CT scan of the chest and whole abdomen for the first 2 years, every 6 months then. Some oncologists also yung patronize already PET CT scan. Although sa guidelines, hindi pa siya level B evidence pa lang siya with PET CT scan, but there are already oncologists who request for PET CT scan for monitoring. Now, after the second year, nagiging annual na lang yung request na yan, yung colonoscopy, CT scan, and CEA until 5 years. Pero beyond 5 years, pwede pa rin i-extend yung surveillance. And dati ang sinasabi nila, after 10 years of being cancer-free from colorectal cancer, sabi, cured na, cancer-free. But then again, because of tumor behavior, we cannot really say that one is really 100% cure for cancer. Kaya nga, ang sinabi ko rin dun sa lecture, tuloy-tuloy ang surveillance and monitoring. I know a lot of patients na kahit na lumampas ng 5 years, 10 years, pwedeng bumalik ang colon cancer. Pwedeng bumalik in some other form of cancer. Parang second primary. So, basta ang magic number na lang 10. Pero I personally do not, I'm not strict about the 10-year na cure.
Okay. Okay po. Another direct message question, ang hemorrhoids daw po ba, if not treated na kaagad, precancerous lesion daw po ba ito?
Hindi.
Almoran.
Hindi siya precancerous lesion. So never niya magiging cancer. Pero yun nga, ganun pa rin. Yung constipation, yung polyp formation, sequelae lang siya because of the hemorrhoids. Ang nangyari po kasi sa hemorrhoids, pag may acute attack ka, pipigil kang dumumi kasi masakit, magko-constipate ka. So it's a vicious cycle. So the constipation per se may contribute, maybe a risk factor, pero not the hemorrhoids itself. Hindi siya tutubo doon sa mismong almoranas.
Okay. Another question. Is there an anatomic landmark of the tumor or resection to see if the patient will need a colostomy bag? So para po sa mga non-medical sa audience natin, Dr. Manzo, explain mo yung colostomy bag. Ano ba yun?
Ang hirap ng mga tanong, ha? Okay, yung colostomy bag, linalabas po yung bituka dito sa may abdominal wall, dito sa tiyan mismo. So there are instances na kinakailangan ang colostomy. It may be permanent or it may be temporary. Karaniwan sa mga nako-colostomy is yung mga nai-emergency. Sobrang laki na ng bituka dahil sa pagbabara ng colon cancer, hindi na screen, hindi elective yung procedure, maraming pupo dun sa loob. So we end up with colostomy. So pinuputol dahil hindi mapapagdugtong, masyadong malaki yung bituka dun sa kabilang dulo. So hindi po pinipilit dahil mataas ang risk for leak. Yun yung temporary. So kung temporary nangyari, babalik din naman yon. Ibabalik din naman yung colostomy, idudugtong pa rin, usually after 2 to 3 months. Yung anatomic landmark po kung magko-colostomy or hindi na permanent for an elective procedure depends on ang ano dyan is yung daliri. So sa digital rectal exam, before, kung maabot mo yung bukol, most probably mako-colostomy ka. Kasi ang kinakailangan po natin is at least a 1 centimeter margin from the lower part ng tumor. So kung na-involve yung pang-control ng dumi or yung sphincter, kung involve yon, hindi natin pwedeng iwan. Kailangan nga natin ng margin. So kung sakali 1 to 2 centimeters lang ang layo, most probably colostomy yun na permanent. Okay? Kaya yun ang isang advantage nung neoadjuvant na chemoradiotherapy for rectal cancer is because yung 1 cm or 2 cm na layo dun sa puwet, pwede pang umangat yon. Pwede pang mag-shrink yung tumor para ma-save yung sphincter at hindi ma-colostomy na permanent yung patient. Yun po ang habol, yun yung isang objective ng chemo and radiation before surgery for rectal cancer. Pag ganyan naman po, ang nangyayari, napipilit, nagagawa ng paraan because of, mahirap po kasi, medyo technical yung sa OR, gumagamit po kami ng stapler pag masyado ng mababa para hindi mahirap yung pagdugtong. And then we make a parang temporary ileostomy para po paghilumin muna yung pinagdugtong tapos ibababa na lang yung ileostomy. So basically, it depends on the margin. So a 1 centimeter margin from the lower part of the tumor, basta't ma-achieve mo yon at meron ka pang matitirang bituka na pagdudugtungan, we will avoid colostomy.
I think this is the last question. This is regarding EGCO. EGCO, I think, is colostrum. So this is like a probiotic. Do probiotics have a role in preventing colon cancer? Because you mentioned folic acid, calcium, and vitamin D can be preventive. What about probiotics? Dapat masagot mo yan kasi nagpo-probiotics ka dito sa bahay.
Hirap yan. Pwede ko ipasa sa'yo. Yung probiotics. Probiotics kasi is more of small intestinal bacteria eh. I'm not sure about I'm not sure really about the answer, I have to be honest. But for probiotics is more of the small intestinal bacteria ang naaapektuhan. So that's why probiotics increases the immunity, the gut immunity and the immunity of the patient because yung small intestine, siya po yung pinakamaraming lymphoid organs, yung lymphoid tissue na nakakapag-apekto ng immune system ng katawan natin. So parang kaya nagpo-probiotics yung mga bata, kahit tayo, to prevent infection. Pero with colon cancer, I'm not really sure. Pasa ko sa'yo.
Very good po. I would have to agree with our lecturer. Yes, we still have to find data, evidences linking the preventive benefit of probiotics with colon cancer. So na yun po, yung mga nabanggit pa ni Dr. Manzo sa kanyang lecture, ang evidence backed up na paraan to prevent. Ang atin pong probiotics are for gut immunity and gut health. May role po siya dun sa tinatawag na dyspepsia, yung mga kabag-kabag natin na hindi related sa malignancy, more of functional disorders, sa mga nagkaka-COVID na may pagbabago na sa panunaw, mga diabetics, mga ganon. But for colon cancer po, Dear lecturer, at the moment, I agree with you, wala pa tayong evidence. Ayan, naubos ko na ba? Nag-check ako ng phone, nag-check ako ng Zoom. Baka meron akong tanong na hindi nabanggit. But I think we've covered basically all of the questions from the audience. Dr. Manzo, I think we can wrap this up. So to wrap up our evening session, would you like to have a few words before we call on Dr. Acosta for his closing remarks?
Well, ano na lang, siguro from the bottom of my heart, I speak for the officers. Thank you po sa lahat ng dumadalo regularly dun sa cancer advocacy namin for the past year. It really, yun po ang aim namin, is to inform patients, inform our friends, inform our loved ones that these cancers can be treated, can be prevented. We can beat cancer together. Pag may questions, andito lang po kaming mga doktor to shed some light on your questions. And hopefully, wag kayong magsasawa sa support for OCMS. Again, thank you. And I pass the floor to Dr. Acosta. This is our last natin, last colon cancer lecture. So abangan na lang po natin yung mga infomercials na ipapalabas namin for April and May na cancers.
Yes. Dr. Acosta, for our closing remarks. Wait lang. I-unmute lang kita.
Yeah.
Yawn. Hold on. Hi.
Mute. All right. Magandang gabi po sa lahat. Thank you po for sharing your time with us. It's a Friday night and I'm sure ang iba po sa atin mas gusto munang lumabas dahil syempre lumuluwag na ang sabi nga ni Dr. Manzo kanina. Sana paalis na ang COVID sa ating mga buhay at since it's a Friday night, I'm sure some of us mas gustong lumabas kaysa makinig ng lecture at matakot sa pagkakaroon ng colorectal cancer. Actually, isa po ako dun sa natakot kasi po ang aking tatay, ang aking tsuhin, na kapatid ng aking tatay, at isa sa aking pinsan, lahat po sila nagkaroon ng some form of colorectal or anal cancer. That's why mataas po talaga ang risk ko personally. Kaya I may be meeting our lecturers and moderators sometime in the future for a screening. Para susundin ko ang lecture na binigay ni Dr. Manzo at upang ma-make sure na nandito pa ako sa paglaki ng aking mga anak. At ayun po, sa mga sumubaybay ng aming mga cancer lectures, maraming salamat po. Marami pa pong susunod na cancer lectures para maitaas ang ating awareness. At ang objective lang po naman talaga namin dito ay early screening, early detection upang mapahaba ang ating mga buhay at ang ating yung quality of life natin na kung sakaling makakuha man tayo ng isa sa mga cancers na ito, mag-improve ang ating quality of life at humaba ang ating life expectancy. With that po, I close the program. See you on our next lecture. At kindly stay for a few moments for our photo op.
You may turn on your cameras now. Thank you, Dr. Acosta, for your closing remarks. Maglalambing lang po. Please turn on your cameras for our photo op. Habang inaayos po ni Dr. Manzo ang ating screen share, meron po kaming lecture next week on rabies awareness. Please attend. Also, kung may free time po, mga pet lovers dyan sa ating audience. At meron din po kaming fundraising for our frontliner nurses. Hope you can support us in this fundraising concert. Dr. Manzo, are you ready to screenshot?
Ready?
Okay.
3 pages. Open your videos. May humahabol pa. Open. Yay!
Okay.
Sana malapit na yung face-to-face. Sana.
Oo nga. Matatapos na itong mga ganitong
Okay. First page, 1, 2, 3. Second page. And last page. Okay.
Hey.
Thank you,
Thank
everybody.
you po sa inyo lahat. Stay safe. Have a good weekend. God bless po.